this is open to all the medical students. They haven't specialized in, like, they're not the residents, but the residents.
It's such a big.
Everybody can come.
Anyone, yeah, anybody.
Yes.
But it's just, residents are working, right?
Yeah, it's hard, that's a hard.
Almost impossible,
Yes.
And they're either working or they're students there.
You can download all of these lectures.
Oh, cool. Oh, awesome.
They're all recorded.
Oh, yeah.
Where are they housed?
This is not for us.
We have them on our website. Trauma
With the-
Central. Trauma
Dollars
Central.
lectures.
Huh?
Okay.
Yep.
I'll give you guys a card that has the links in it. It'll actually.
I love that, yes.
Right, I will, I'll do it.
Yeah, help yourself. We have the Casey Film Fest.
Oh, cool.
That's gonna be a film. Yeah, it's really cool. Parker, Matt Jacobson. But that's gonna be a film festival. Big. I guess AMC complex, it's got like 24 theaters in there. Yeah. Have you ever been to a film fest?
No. Or actually, wait, yes.
They're fun.
Yeah.
Which one?
I did media stuff in high school and college. So that's what I was trying to think of, like somewhere. It's more like the jack of all trades, master of none.
Oh, yeah. Oh, yeah. I know that.
I was like,
Hello?
trying to figure out which one it was when you were
Oh,
talking
oh.
about that program.
I had no idea. Nope, none.
Yeah, right.
For the meal.
Okay, I'm gonna sit there.
Okay, that's me.
Hey, if I can do it. And Dr. Abebe said your presentation will be excellent, so.
Oh, well, you know what, he knows what he's talking about.
You've had a meal. You're doing it.
Yeah, that's true, I've done hard things. Just don't like, I like to talk, but not.
That's awesome, you got a picture of the bike.
Yeah.
I love that picture.
Yeah.
That's so cool. Yeah,
So
it's awesome.
Yeah, the organization that we volunteers with is, one of their goals is to get people using just bikes as transportation here instead of being so dependent on cars and things, but also, they try to get, they try to get bikes to everyone, available to everyone, regardless if they're willing to pay for them or purchase them.
Oh.
Open for helping them do repairs on the bikes that they already have and just, kind of like, pay what you can as you can, sort of.
I know we talked about the international.
Yeah, oh, I think.
Right, how that
I did, yeah.
Health.
You remember Lana?
Yes.
I know she just.
In America.
Yeah.
Yes.
Well, my sister actually works in that.
What's her name?
I couldn't tell.
Okay. Oh my gosh, that's crazy.
Yeah.
Okay.
Yeah, but,
Wow, that's awesome. Yeah, we worked really closely with them.
yeah, that's great.
Okay, here you go.
Yeah. Kim texted me
Thank you
this
so
morning.
much. Appreciate that.
It turns out,
Thank you.
Future's new housing arrangement is pretty far away and
You
has a
love
lot of
it.
hills.
It's
Yeah.
like,
You
this
raised
Friday
money,
has
I got
special
it.
vibes.
We're on that. On top.
Okay.
Where's
Like a mile away from campus almost.
Very hilly, no sidewalks,
Right.
not the best situation.
You know how state line when you're going north towards Southwest Boulevard turns into Eaton, and there's all the
Yes.
duplexes and everything?
I've had people stay there before.
So he's down Eaton and then you turn.
Recording in progress.
Go up some more hills and he's in one of the duplexes over that way.
She just remote.
Good afternoon, everyone. Thank you so much for joining us in person and on Zoom. This is the Office of International Programs, Foundations of Global Health in conjunction with the International Orthopedic Trauma Collaborative. I am Alexa Smith and I am the Educational Exchange and Event Program Manager with the Office of International Programs. Just a little bit about our series. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that's from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. Presentation number 9 will be on March 25th on building a hospital to impact the trauma epidemic. So be sure that you sign in if you're in person, or if you're on Zoom, make sure I can read your name so I can get the information to you. And today we have a special guest with us. We have Future, who is the current Redford Fellow. And just a little bit about the Redford Fellowship. The Redford Exchange Fellowship Program was established by the Redford family in honor of their mother, a lifetime nurse at KU Medical Center, to bring in nurses from international sites that support our students' international educational experiences in order to give the international nurse mentor an understanding of the United States healthcare system, and more specifically, the nursing education system and program. The award fully supports a 4-week exchange at the University of Kansas Medical Center School of Nursing, and Future is our 5th recipient. We have a list here of our past recipients, and so we're glad Future's here with us. And without further ado, I will turn it over to Talon.
Thank you, Alexa. So today we're going to talk about the nurses' contribution to combating the trauma epidemic. And as Alexa said, my name is Talon. I'm an M1 here, and I'm part of IOTC and ATI. So thank you for having me here today. So to start us off, I just wanted to give us a brief overview of some of the lectures that we've already done, which are all able to be downloaded as well. So the first was an introduction to orthopedic trauma. And so on that, we really focused on how when you have well-developed trauma, that type of science saves lives. So we talked about the importance of having that science and what can happen when you don't have that science available to you. Next, we did a brief overview of ATI. And for that, we talked about how trauma deaths and deaths associated with trauma are a reversible epidemic. So it doesn't have to be happening. So what can we do to change this? And then in the third lecture, it was one of our etiology of trauma epidemic lectures. We've had 2 of those so far. And on this one, we talked about road traffic accidents and work-related injuries, as well as poor infrastructure. And then in the fourth one, it was a brief history of medical missions and similar interventions. And with that, we talked about how faith-based aid can end up supporting trauma care and the necessity of having that right now in order to change what is going on and being able to do interfaith type work. And then for the 5th lecture, it was another one of our etiology of trauma epidemic lectures. And on this lecture, we focused on the conflict-related deaths and self-harm due to poverty, instability, and poor infrastructure. And then for our 6th lecture, it was the economic impact of orthopedic trauma. And this was actually last week. And here we talked about how trauma burdens individuals, communities, and countries. So it's economics all around. It's not just one person, and it's not just because something happens to one person continents away. It doesn't mean it's not going to impact us. It is. And then, so for today's lecture, we're very lucky to have two key speakers, Lori and Future. And with Future, we're kind of talking about how he's one of the Redford Fellows, and he's the first nurse fellow for IOTC. And then for Lori, she is the director of the International Nursing Fellowship, and she's one of the OR nurses here at KU. And in the lecture, she's going to talk about many things for us. And I think for me as a medical student, so I think for the students out there, or people who haven't been in an OR, she's kind of going to give us an overview of, okay, this is what's happening in the OR. These are the people here. And I've been in the OR before, and I didn't realize that when she was showing me the slides. So I think that will hopefully be very impactful from an educational standpoint there. And then she's also going to talk about the cross-cultural understandings and how nursing can change across different cultures and the capacity building that's needed, and then also the knowledge exchange and why nurses operate the way that they do when they're in the OR. And then Future is going to talk about his experiences as well. So without further ado, Lori, I'd love for you to come, and this is a slide for later when we have the panelists who are going to do our panel. So.
Everyone, thank you so much for being here, having me. It's such an honor to be part of this organization and to have the opportunity to speak to you all about my experience. Okay, I'm so bad with technology. So I wanted to do this a little bit later, Alexa, so I'm just gonna click ahead and see what happens. Is my lecture on a different screen? Maybe I'll do the video now. Oh, well, that's interesting.
Recording stopped.
Should have got them all in there, I thought. Well, we're just gonna do it this way. I have it on my computer too. I don't know if that makes any difference. No, I just gotta remember what my password is. Oh gosh, right. I have to my computer just does it all. That's, I think, that's the, that was the one. That's the other one. Yeah, that's Taylor's. Oh, that's the one. That's the here it is. Okay. That explains it there. Okay, good to know.
I have to change the type. Is it key file won't work?
I'm gonna try that because that usually will do it for me.
I have it saved as a PDF. If you want me to send you that, Alexa.
Yeah, because this is not cooperating with me. For some reason. Yeah, it's okay. Oh, don't worry about it. I had Zoom crash on me 4 times earlier today when I came in here, so it's fine.
Always something.
It's fine. It's all good. So if you haven't gotten anything to eat or drink, or if you would like a refill,
We can show the nursing clip too if you want. We can just show that now, just to get the ball rolling.
I think it. And I can just, well. So, yeah, we can. I can't see that. Yeah, okay. Cool beans. I just want to show that right now. So yeah, this is just a clip from the documentary that we're working
Yeah,
on.
with there is road traffic accident, falling accident, and blunt injury and gun injury. We don't have adequate supplies, so we don't have adequate our orthopedics, implants, screws, everything. We have a lot of scarcity.
Standard in the OR is solid surface flooring. We just don't use tile in the operating room, and you can even see that these have cracks. The grout lines, it's all very dirty. There's blood on the floor. It's hard to clean it out of a hole in the ground, and that just breeds bacteria.
The nurses in Ethiopia, they have a lot more responsibilities than what we have in the operating room here. The nurses take the instrumentation after surgery and they start the washing process.
So they're hand washing everything first before they sterilize it, so it can miss bioburden or any debris that might be on there, which can cause contamination. So
Washing machine
yeah, we have a washing machine, like a big washing machine. We put our sets in there.
is working, but the water is not okay.
Also, just hand cleaning, it's all contaminated with blood and tissue, and it puts nurses at risk. So, or whoever's handling the instruments.
The nurses are in charge of their own scheduling as well. They're in charge of cataloging the implants that come in and making sure that they have all of the correct plates and screws and things like that that might be needed for a surgery.
So she keeps track of what they have. And this is some of her, the implants that they have. And here is where they keep the sterile instruments, so they can come in and pick the instruments that they need for a case.
This is orthopedic instruments.
So one of the biggest realizations I had while working alongside nurses in Abbott Hospital in Addis Ababa was that there are so many similarities. We share a similar language that we speak. There are standards that are evidence-based, and we as nurses follow them. But there's also this subtle language that we use that just comes with being a nurse. Even with limited resources or limited space, we're still speaking that same language. There's also very important differences. They're having to do with much less. They're repurposing and reusing instrumentation, supplies, and they have limited access to implants.
Bone is a framework. If they lose that bone, they cannot work. They cannot live also.
So it's a little piece of our experience while we were in Ethiopia.
kind of a big file with how long it's taking it down the pictures I think make it worth it.
Oh, we have to have the picture.
Yeah, I mean, pictures help to illustrate the story, you know. This is like, this is the experience, this is what's happening, and in order to understand that, you need pictures. That's okay.
There. We're getting there. Getting there.
I really appreciate how you're saying that, like, yes, you have this common language because you're in healthcare, but like there's just this like unspoken like subtlety that like you're both nurses and you share that and you understand what each other's saying, even though you've got like these different backgrounds, different experiences, but it's like that underlying like being a nurse
it was really surprising how I would hear them talking and I'm like, it's so much what we're saying here too, you know, the same complaints, the same struggles. Yeah, a lot of it is so similar. And it connects you, you know, to have those.
Exactly.
I have a question.
Yeah.
I briefly talked with Future in regard to like the International Federation of Perioperative Nurses. Have you found that in the various locations that you've gone that they follow those standards since it is like a global organization?
Yep. Yeah, when I was first asked to do this with the nursing fellowship, that was one of the first things I looked at was like, what are the standards that they're following? How do we have overlap? Are they following standards? You know, that was definitely one of the things I first looked at. And for sure, yeah, they are definitely thought of overlap. Yeah. Mm-hmm. They are incredibly intelligent. Like a lot of them have more education than me, even just being a staff nurse. So Helena, the nurse that was featured in that, she's a master's degree and just a ton of experience. So they're very well educated. Yeah, and one of the things I go into is that what we're learning from them just as well, you know, because what they're seeing over there is different than here, and we can take, you know, what we see over there and take it to how we practice here. Yeah, we'll get to that. Taylor, thank you for saving the day.
I don't know if you want to, but I think you could scroll on this, but it's not.
Oh, yeah.
We're almost there.
Yeah. Yeah, try that, exactly. What the heck? 16 seconds left.
Oh, maybe that's why.
Yeah.
I would
It said it was
explain.
ready.
Well, it lied.
I was really excited. I know.
It lied. And then
scroll through here. All right.
Yeah, you just. I want to my screen. And okay, we are back in business.
Okay. All right. Thanks again, Taylor and everybody for that. So yeah, we're going to talk about the impact on the nursing and the impact on the global orthopedic trauma epidemic. So we're going to go into, it's just an overview. When I talk to people about this, even people who know me well, a lot of times people don't know what orthopedics is. They don't know what a surgical nurse does. A lot of times I'll say, yeah, I do orthopedic trauma. And they're like, whoa, so you're in the ER. And I'm like, well, no. So I understand that a lot of people don't even know what happens inside of an operating room. So we're going to go into that. Did the intro. So I wanted to first start talking about, there's a medical model of care and there's a nursing model of care. I think this is important just to address right off the bat so we understand that this is something that's foundational as nurses. So nursing integrates the art and science of caring and focuses on the protection, promotion, and optimization of health and human functioning, prevention of illness and injury, facilitation of healing, and alleviation of suffering through compassionate presence. Nursing is the diagnosis and treatment of human responses and advocacy in the care of individuals, families, groups, communities, and populations in recognition of the connection of all humanity. The nursing model of care is a holistic model of care. The nurse is trained to see the patient as an individual with unique physical and emotional needs and is taught to educate the patient and their families on
Recording in
strategies
progress.
to maintain health and independence. The nursing process relies on the following components to care for a patient. ADPIE is the acronym. Assessment, subjective and objective information is collected. Diagnosis differs from medical diagnosis in that this will be used to provide a plan of care for the patient, both short-term and long-term goals. The nurse will use their clinical judgment to determine actual or potential problems that may occur. Planning, the nurse sets goals and desired outcomes personalized to each patient. Implementation, the nurse carries out the course of action. The care plan is documented in the patient chart. Evaluation, the patient's status and the effectiveness of the care plan are evaluated and modified as needed. So that's foundational to us. We're gonna just kind of keep moving here. So, perioperative nursing. What is perioperative nursing? There are multiple roles that play in the perioperative field. So there's pre-op nurses, they prepare the patient before surgery. There's intraoperative nurses, they care for the patient during surgery. There's postoperative nurses, and they care during the recovery after surgery. The perioperative environment is considered a critical care unit and requires specialized training and skills. Currently, there is very little focus on perioperative nursing and education in standard nursing school programs. I chose to teach my son at a very young age. Most student nurses may spend a few days observing in the perioperative environment. Some nurses choose to pursue a practicum or internship experience in the operating room, in which they will spend at least 3 months training with a nurse. New nurses hired in the operating room at the University of Kansas Hospital in the Bell Hospital operating room receive 6 to 7 months on-the-job training in orthopedics, general surgery, urology, gynecology, plastics, and transplants. They are trained to scrub and circulate. So there are 2 basic roles in the operating room, the circulating nurse and the scrub nurse. You can see here, this person is not sterile. These people are sterile. So we have our non-sterile person, which is the circulating nurse. He or she organizes the instruments and equipment needs. They facilitate interdisciplinary communication between anesthesia, surgery, pre-post, radiology, pathology, radiology. They assist the scrub in the sterile field setup. They assist with positioning, preps the surgical site, aids in draping, and is the non-sterile hands during the procedure. So they can open instruments and supplies as needed, observing the sterile field and monitoring the needs of the patient, counting before, during, and after the procedure. The circulating nurse is the liaison and advocate while the patient is undergoing surgery. They are also responsible for all required charting and documentation. The scrub nurse's primary role is the sterile assistant to the surgical team. They maintain the sterile field, both the setup of the instruments and the draped site. They attend to the instruments and pass them to the surgeon as needed, and they work with implant reps to ensure the correct and appropriate implants are used. It's hotly debated in the internet world on which role is more important, but we know they both are important. Here at KU, we have multiple support roles as nurses. We do not function in these roles, so these are people who help us in the operating room.
So surgical support staff, our S3s are people who help clean the rooms between cases. They help us turn over everything to get ready for the next case. They assist the nursing staff with equipment. They help transport specimens to and from the lab. So that helps free us up to do other tasks. Unit coordinators, they run the daily surgery schedule, organize nurses' schedules, interdisciplinary communication. Team leaders, each surgical service line has at least one nurse team leader. This person helps make assignments, helps organize necessary equipment, instruments, and supplies for each case, is the point of contact for sales reps, and often for surgeons as well. Anesthesia techs, they assist and support the anesthesia team, help with equipment, clean and restock anesthesia machines during turnover. Biomedical engineers, they maintain equipment and are available as needed to troubleshoot when equipment needs acute intervention. We as nurses can do some of that troubleshooting. I utilize biomedical engineers quite a bit. If I'm in a pinch and don't know how to fix something, they're very responsive and wonderful, so they can help us with our surgical beds, lights, screens, cameras, really so much. Anytime I need something that is broken, I call them, and it happens more often than you'd think. Radiology techs, they maintain and operate portable x-ray machines, intraoperative fluoroscopy, the C-arm, and intraoperative CT, the O-arm. We as nurses are not able to operate those, so we have to have techs for that. Sterile processing, the staff that manages the reprocessing of reusable instruments. They clean, package, sterilize, and store sets and individual instruments. Again, that frees us up from not having to do that task. We have physician's assistants and nurse practitioners. They help with documentation, orders, informed consents, notes, assist in draping, assist surgeon in surgery. You can see, and there's probably more. Like, there's probably more support people that I have not even listed here. Okay, so orthopedic surgical nursing. So I was telling you how nurses at KU will go through 6 to 7 month training. We are trained in all the specialties, and then you can kind of subspecialize and work in a specific unit. I work in orthopedics. So the orthopedic specialty presents unique challenges to the educational and skill set needs of nurses. Orthopedics utilizes highly specialized tools, equipment, instruments, and implants. Patients undergoing orthopedic surgery require an array of possible surgical positioning and the use of specialized positioning devices and beds. Further, orthopedic trauma patients present with unique medical and surgical needs that often spread across multiple specialties and require acute care. All of this can be very overwhelming and often anxiety-provoking for nurses caring for these patients. Nurses also report an increase of physical stress and strain associated with working in orthopedics. Standing for long periods, wearing lead, lifting heavy equipment and instrument trays, positioning and prepping heavy or awkward broken limbs, etc. Anecdotally, it is generally understood that nurses do not particularly like working in orthopedics. It has a reputation for being a hard specialty. So it can be hard to keep people interested. Turnover is pretty high. You can see this is, one of our setups. She's got trays stacked. This is for some sort of implant case, and oftentimes this is very familiar in orthopedics. This is some of our equipment. So we've got, this one is just some of our positioning devices and prepping, and you can see there's a table for prepping arms, so we need to have a knowledge of all this stuff. This is a tourniquet. It helps occlude blood vessels so the the surgical site is not actively bleeding. We have to know how to operate that, and obviously that's an important piece of equipment to know how to operate. This is our lead that we wear when there's radiation. This is more equipment that's for spine, that's some spine positioning, more positioning. This is just like some of our basic equipment that you see in the OR. Suction, cautery, a bear hugger. These are all, this is in an actual orthopedic OR, so that was all that was used. This is a video. I don't know if it's going to go, but this was a video of just the spine instruments, the extra spine instruments. I wanted to show you guys like how much instrumentation there is that we have to know. That was just for spine, but it's a lot, I'll tell you. This is just a room that's being used as storage right now. You can see some of the beds that we use. Different beds. This is for beach chair positioning for shoulder surgeries. It's all very complex. It's kind of bulky. People don't like them. This is extra orthopedic supplies, just peel pack supplies, so just individual instruments. You can see there's quite a few. This is all extra orthopedic stuff as well, implants and just like extra disposable things. And you can just see some of our basic pans here. Okay, so ortho nurses at Abbott Hospital in Ethiopia. So nurses working in orthopedic surgery at Abbott Hospital have the same responsibilities as nurses at KU. Nurses also take on the support staff roles: team leader, coordinators, biomedical engineers, DNCTM, sterile processing, implant reps. Everything I mentioned before, they're doing that. Nurses also feel the same insecurity and overwhelm about working in orthopedics and have additional cultural concerns, fear of radiation, influence of traditional hearing practices, etc. Nurses have to function on less supplies, less instruments, less support staff, less resources overall in order to perform the same tasks we perform at KU. You guys saw the video earlier, but this is some photographs of the hospital. You can see a lot of it is very similar. It's very much the same kind of stuff that we're using. A lot of times it's all just reused. They'll reuse that cautery pad until it absolutely is not working anymore. That bed is actually not in working repair, so they can't use it, but it's a good example. So here she is. I was saying how they kind of operate as the implant reps. So she was getting through a bunch of nails, and the surgeon had told her kind of what size they might need for the next case. So she was wrapping it up and sterilizing it. So she's doing, we have reps that are there with us, and they have just any size available to us that we want at the ready. We measure it in surgery. They don't have to guess beforehand. So it's a huge privilege. And then this is her showing the CRM machine. So it looks very much like our CRM machines. Here's their lead. They have to log implants. They log everything by hand. I have the privilege of doing it on a computer with my sales reps. Very much easier. Okay, so what does the research tell us? Research consistently demonstrates that higher levels of nursing education are associated with improved patient outcomes. Hospitals employing a greater proportion of nurses with bachelor's of science in nursing degrees report lower patient mortality rates and enhances quality of care. Research indicates that every 10% increase in the proportion of BSN prepared nurses within a hospital correlates with a 5.5 decrease in surgical patient mortality. This suggests that hospitals with 80% BSN qualified nursing staff experience mortality rates approximately 25% lower than those with only 30% BSN qualified nurses. An investigation into the links between satisfaction with nursing education and job satisfaction revealed that the positive educational experiences are associated with higher job satisfaction and a decreased intention to leave the nursing profession. This underscores the importance of quality nursing education and retaining a committed nursing working force. What about in Africa? Research indicates that enhancing nursing education in Africa positively impacts patient outcomes. A study at the University of Benin Teaching Hospital in Nigeria found that nurses with higher education levels were associated with better patient care outcomes. The study concluded that investing in nursing education is essential to improving healthcare quality, patient safety, and outcomes. In sub-Saharan Africa, challenges such as insufficient resources and a lack of trained educators have limited nursing education, leading to shortages. Blended learning, which combines remote learning with clinical components, has been proposed as a solution to increase the number of qualified nurses in rural and underserved areas. A review of perioperative nursing education across Africa revealed that specialized training programs, though limited, have led to improved knowledge and clinical skills among nurses. These enhancements are associated with safer surgical care and better patient outcomes. These studies underscore the importance of investing in nursing education to improve the patient outcomes across various healthcare settings in Africa. What do we know? So research tells us that increased nursing education increased positive patient outcomes. We've known this for a long time. Anecdotally at KU, we know that increased nursing education and experience improve surgical team dynamics, effective communication, knowledge of procedures, ability to troubleshoot, sterility. Surgeons at KU report a nurse's competence and confidence results in more cohesive rapport, decreasing a surgical patient's wait time, time under anesthesia, and surgical team frustration, Many surgeons report a desire to have a surgical team with knowledge and experience in their service line. Although research is limited, it does support this theory. Proper training and education opportunities help increase job satisfaction and retention among nurses. So, research indicates that nursing education significantly enhances nurses' confidence and competence, which in turn positively influences surgical patient outcomes. The collaborative nature of surgical teams suggests that well-educated and confident nursing staff can contribute to an environment that bolsters overall team performance, potentially enhancing surgeon confidence as well. Enhanced nurse confidence and competence. A study published in PubMed demonstrated that even low-intensity educational interventions improve nursing confidence and competence in performing surgical tasks. The research highlighted a positive correlation between increased confidence and improved performance, suggesting that educational programs are effective in enhancing nursing skills. Simulation-based learning versus problem-based learning. Research comparing SBL and PBL methods found that both approaches improve nurses' core competency, satisfaction, and self-confidence. Notably, SBL was superior, enhancing these attributes, indicating that immersive hands-on training methodologies are particularly effective in preparing nurses for surgical settings. Impact on surgical outcomes. The American Association of Colleges of Nurses reported that higher levels of nursing education are linked to better patient outcomes. Specifically, a 10% increase in the proportion of baccalaureate-prepared nurses was associated with a significant reduction in patient mortality and failure to rescue rates. This underscores the critical role of advanced nursing education in improving surgical patient care. Existing studies and anecdotes affirm that enhancing nursing education leads to improved nurse performance and patient outcome. This in turn fosters a more competent and reliable surgical team environment, which can positively influence the confidence and effectiveness of surgeons. So what can we do? So research has a large focus on nurses with bachelor's degree and the impact it makes on patient outcomes. But we can assume more hands-on training, even beyond the academic setting, can improve surgical confidence and patient outcomes. As developing countries grow their orthopedic trauma programs, education needs to extend into training nurses on advanced surgical techniques, equipment, and instruments involved, and increasing their confidence and knowledge. As we train and educate surgeons, nurses need to be trained as well. IOTC has developed a nurse fellowship program to help fill this gap. Nurses spend 6 weeks in an observership program with KU with expert nurses with a focus on orthopedic trauma. We hope to extend this to all aspects of the ortho trauma patient's care, the intraoperative care and the stages of recovery phase, the time directly after surgery, and as well as the follow-up phase. We can travel to trauma-burdened healthcare systems in low to middle income countries to observe and help create awareness. As we work directly with nurses in their home country, we simultaneously learn more about how we can assist in their education needs and tailor the way we interact with their learning experience. But we also learn how we can improve or change our own practices to improve how we treat trauma patients at KU. It can also improve overall interest in the field and hopefully increase nurse satisfaction and retention. Feeling like a valued member of the team increases nursing satisfaction. We can help provide necessary equipment and instruments that play a vital role in the nursing care of patients undergoing surgery. Along with providing these necessities, we train nurses on the operation and maintenance of the equipment. Increasing awareness of programs offered to nurses at KU can help increase interest and competence locally, include nurses in lectures, journal clubs, research, and create opportunities to work alongside med students, nursing students, and faculty. Give value to nurses' input and engagement in the evolving and growing healthcare field. We continue to evaluate and imagine ways we can improve the lives of trauma patients here and abroad. We advocate for and assist in continued research and work to expand the global nursing communities in collaboration with surgeons, residents, medical students, and nursing students. There's that video. Okay, so Future, if you want to come up and talk to us a little bit about your experience in Zambia. So if you want to just click through the pictures, it's right here.
Good afternoon. Thanks very much, Laurie. Yeah, so I'm calling myself an imported nurse, coming from a lower mid-income country and comparing with what you people are doing here and what we're doing back home. It's quite an experience, and so far I've learned so much that I'm going to share with my friends where I'm going. And also, I hope I've also been sharing our experience or what happens back home, that I'm also sharing knowledge, at KU. Yeah. So if you look at what we are doing, from the picture here, first of all, I like the presentation for Lori. It is comparing with two hospitals, if you are following very well. She gave an insight from, Ethiopia, and then she gave an insight from KU, and then she mixed. So if you see me coming in front here, I'm definitely acting like a testimony, okay? Coming from the lower mid income, and also as an ambassador for KU also, since I'm here. So I'm here to testify that what Roy said was very true, and this is also our experience back home. It's quite, it's almost the same like what Ethiopia is experiencing. So this is our operating room. If you see from the picture, these are just empty operating room that we have the vision to continue, patient care, but because of limited resources, you can see that's our theater. We're supposed to have 3 operating rooms now, but because of lack of resources, actually 4, but because of lack of resources, we are only operating with 1. So if you can see from the picture there, you can't have any surgeries there. There's no table, there's no anesthetic machine. There are a lot of a lot of things. Those who've been to theater, you can see. So our prayer, which is almost being answered, we are getting implants through Dr. Heading, IO, TCT, who are coming in with the help of this international program. So probably we'll be able to set this operating room, because we are quite overwhelmed with what we do there. We have a lot of patients, but because of lack of equipment, instruments, we are unable to. So that's just our hospital. This is our, we call it TSSU, Theater Sterilizing Unit. So this is where we operate. If you see from this, we have our drums there. Then we have people packing. Here we use just linen. I've been seeing here you're using those disposable drapes and so on. As we use linen, the purpose is, if we use those, it means it is once off, and because we lack resources, we cannot use something that is disposable. So that's why we are using the cloth or material as linen, so that when we work, even though they are blood, but we are still able to sterilize them back in the autoclave and then reuse them. So if you can see, this is one of also my roles that I do. If you see from this picture, we are packing this, right? We are making them into drapes. But after packing here, after packing the sets and everything, I also have to go and assist in surgery. If you see, this is me here. This is Professor Mula, one of the doctors, that we operate with. So this was an ankle surgery, for example. We made 2 incisions, this side and this side, and I'm suturing the other side. He's suturing the other side. And we just bring in someone to help us cut with the scissors here. So this is because we have a lot of patient line that we need to finish this case first, okay? So that we focus to the next. So that is what is happening here. So we quite, we're exposed to a lot. So also, this is our OT room, because, this is a full set that here I've seen a situation where first someone has to scrub, first they pack instruments, right? Then later on they remove, and then, they now start the procedure. But for us, we're using, if you see here, I hope there's that container there, where we put our Cheeto forceps. So I'm not actually touching this, it's because of maybe the camera angle. I'm actually touching this with a long forceps, a Cheeto forceps. So I'm just touching something sterile and I'm throwing on the table. I'm not scrubbing, because our fear is if you scrub again, you are going to throw, because you don't have a lot of equipment. So you simply touch with something that is, it's a long forceps that you just carry instrument and press there. So yeah, so that's how we prepare. And then after that, I have now to scrub, after scrubbing, then professor comes in there. Professor Mola is an orthopedic surgeon. He's quite experienced, like Dr. Arch Headings. Yeah, he's our Arch Headings of Africa also. So yeah, he has to dress up, and then After that, we operate together, okay? So then I have to stop assuming the role. If I was acting a role for a surg tech, now I have to assume a role of as a medical assistant or surgical assistant. So I have to do both roles to make sure we finish the operating room. Then after that, we have to finish the case. This is just a summary that I wash the instrument, then I have to go and dry the instrument. So as you can see, I was laying them there. So then the case is done. Then you have to wait for the next case. So, and then, like, you know, our work is similar, but for us, because of, you know, lack of resources, so we quite try to improvise a lot. So if you can see, these are cutleries, we call it diathem pencils. I hope that's the name also. Okay, so these are cutleries. We just, once after using them, because we reuse, we can't use one cutlery, you know, as a disposable. That's why here I'm getting surprised. You are from using one and then they are throwing, and I'm wondering, are you really throwing that? Then they'll say yes. I'm like, oh, okay. Oh, I'm from, yeah. So we have to, you know, wash these and then we have to pack them. This is our, something that helps us to autoclave through radiation. So we just pack them there and pack them properly. So this is, these are cutleries, and then we have our bipolars there. So we have to pack them properly. And also for the suture, you can see there are some sutures there that sometimes you just don't want to throw, because if you throw, you know, you'll be in need of them because they are quite scarce. Most of the things that we use are scarce. And then because of how we run our programs also, we've dedicated Wednesdays specifically for pediatrics. So we do pediatric cases on every Wednesday. We call it the CBR, it's a CBR program. So these children, they don't pay anything. We go in the villages. I don't know if you can see properly from this. Most of these children are children with disabilities. We go in the society trying to screen children with disabilities, and then we dedicate Wednesday as a day of surgery to them for free. So we go in the communities, we bring them, and then we do surgeries. Those that need surgeries, we do. But there are those cases that, for example, you know, Down syndrome and other cases that are not, you know, surgical, that you cannot do surgery on them, but a child is, you know, is disabled, has a disability that you cannot operate on. So that we just bring them also to join others, for example. Yes. So, and then this is a day where we just get to celebrate with them every year. We get to celebrate with them. Their mothers come, and as you can see, it's quite a lot. They are all behind there. Their mothers come to celebrate with them, and then you have gifts also. Just little that you can share. That you can do. So this is some of the gifts you can see we are giving. That's quite our staple food in Africa and Zambia especially. So this is meal. When you give someone this, they'll appreciate you for the rest of your life. You've done an impact to them, because this is our staple food. This is, you know, the corn. You grind it. It's like meal. So, and then you can eat it with any relish and so on. It's our staple food. So that's just, you know, people are giving those gifts. And you can see there's another child here. You cannot quite operate, but this is a child with, you know, I hope it's okay there, yeah. So there are a lot of children coming. She cannot stand, she cannot do anything, but she's just there sleeping. But at least she's able to, you know, celebrate with their friends, also are able to walk with other disabilities. So that's what happens. We just try to, you know, celebrate with them. So basically, you can see that we are limited with resources, but our goal, like Rory said, is to achieve the same thing. Yes, I try to relate our case. This is my own, from my own mind on how I relate. If you read theoretically, there's a way the body tries to, for example, if you are fasting, right? You are fasting, you can fast maybe for 3 days or 1 week. There's a way the body tries to generate itself. For example, if you don't have anything, the body would try to, maybe the excess energy that was stolen, for example, you know, from maybe glucose, you store from glycogen, right? And later on, if you need that energy back, the body will convert back from glycogen to glucose. You're able to need to, you know, to use that energy for your body's function and so on. So for me, this is how I relate our situation, whereby you don't have a lot of instruments to use, but you are using whatever you have to get to achieve your goal in case of, you know, glycogen being converted back to, you know, glucose for energy. So that's how we see. We want to maintain the same, you know, we want to either interlocking nail or a total hip, want to do the same case, but because we don't have, so we're trying by all means to use the little instrument that we use to achieve the same case that, for example, the same case that you are doing here at KU. So basically, that's what we do, and my experience so far has been very good. I'm learning quite a lot, and most of the times I'm always wondering on how you people are so blessed with a lot of instrumentation, with a lot of technology. Me, for example, I'm seeing robotics for the first time. I've just heard of it, Now I get to experience to see the actual, robotics, and a lot of instruments that I just used to learn back in school, because in school you learn everything. You learn everything. This is how it's supposed to be done, and so on. But the problem is, because you don't have those instruments, you have no option, but you have to adjust, like the example of the board that I gave. So you have to adjust so as to achieve the same purpose. Of course, with goal number 1, you have to maintain sterility, just as they do globally, and also at KU. You have to maintain patient safety, you have to follow proper guidelines, and so on. But because you are limited to some resources and so on, so you have to try by all means so that you maintain the same standards. So I very much appreciate that I'm here, and thanks to this program, to the Office of International Programs, thanks Dr. Heddings and the OIOTC team that enabled at least me, who was even able to travel for the first time, to come and experience this and compare the knowledge that I have, and share it with my friends. Now I'm sharing it with KU. So thanks very much, and I appreciate. Thank you.
Future and Lori, thank you so much both for coming up and talking to us and explaining about your guys' experiences. And also, I think, again, for me as a med student, just hearing everything that's going through you all's head constantly when you're either in the OR or outside of the OR, and the way that you're thinking about your patients, it was very beneficial to me. So thank you very much for your time. So now we are going to start our panel, which was on the PowerPoint earlier. Okay. Okay. Okay.
Just do that. Okay.
And so in today's panel, we have Future, who was just talking. We have Kara, who's also an operating room nurse. And then we have Lori, who's also speaking. We have Dr. Heddings, and we have Dr. Beza. And Dr. Beza is from Ethiopia. So just to kind of give yourselves a set mind on what's going on. But Future, I wanted to start with you because you were talking about how with the kids and the pediatric work that you guys do on Wednesday, how it's free for them, and how you guys go into the villages and you figure out, okay, who's needing what, and let's help them. So I was wondering if you could kind of talk a little bit more about the logistics of that, like who is going into the villages specifically? Is it you all? Is it another team that you then converse with and figure out, or how does that work?
Okay. Thanks very much for the question. So for the children, we realize that our hospital, we do these cases also to generate income to run the hospital. Otherwise, if you don't generate income from some of the cases that you do, then you'll not be able to run. Already we don't have resources. So to answer the question now, the same resources that we raise also, that's why we've dedicated that Wednesday to, we've dedicated to the children because it is for free, but we use the same resources for the same cases that also we make the other patients pay. So we use the same resources where we go, we have a team just there by the hospital. Those people now, they go in the outreaches. So we have, like, for example, the physiotherapist involved, also our department has theater, and also some, whenever Dr. Patrick is free and other doctors around there, to go in there, it's an outreach. So you go, for example, there are very little villages, so sometimes we dedicate to say, okay, this time we're going to this compound. So if we go to this compound, but already we had already communicated to them that we'll come, for example, on this day. Let's say we'll come on Saturday. You should, all those community or mothers, parents with children with disabilities, as long as they have a disability, please, we'll come on this, such a time. For example, maybe meet at 10 a.m. So you go there, you find them actually waiting for you. then now you are able to screen them. For example, okay, this one was maybe a cleft palate. Okay, this is the surgery that is needed. This one maybe has, you know, contracted. There are those students that maybe they have developed bends and the hand is contracted like this. Others maybe with extra digits. Yeah, others with other, you know, bone diseases and so on. Others you find that you actually need to do advanced, you know, procedures like DHS, dynamic hip screws. So it's expensive procedure, but because you are dedicated to do it, you just have to do it, you know, on free. Others they even need, you know, total hip or total knee, depending on how, because there are other children that in our villages they look very young, like in age you see like someone is young, for example, but maybe they are something, you know, because of stunted growth and something like that. So we dedicate those children with the income that with the little income that we raise to go in outreaches, identify the children with disabilities, and then we bring them so that we offer them, you know, free surgeries. Not that we are able to. The others that we just offer just drugs because we cannot do surgical, maybe they are just in pain and so on. So we also try to relieve that. Sure.
Thank you so much for providing that information. And I'm gonna look through some of the questions on the chat, but while I'm doing that, I was wondering, do the rest of you all, can you talk to how your practices are able to do some community outreach or patient education? Like, how does nursing go beyond just the operating room in your experience?
We don't do a ton of outreach, unfortunately, with the operating room right now. I know there's a lot of nursing outreach. It's not something we offer at KU, as far as I know. Do y'all know anything surgical?
We are in a saturated system, so it's the exact opposite. So we have plenty of healthcare providers, and those healthcare providers and health systems are competing for patients. So it's, if we do outreach, it's advertising, and it's coming to us, and it's to convince people that we're the best, and so, you know, that's what every health system is trying to do, right? So it's so interesting. It's just like two completely different health systems.
And I want to take it to Dr. Bebe on the chat, who was asking, well, first, he said great presentations both, which I agree. But then he asked, what are your main frustrations in your practice?
Wow. I'll answer this in my own view. I feel like in every work environment there are frustrations, and again, in every work environment there's always something you can learn about. So coming from an African setup, I feel like the only frustrations we have, not only maybe I have quite few, is one, you want to do the best, but because you are limited, you cannot actually want to do the procedure that you want to do. Sometimes, I'll give you an example. This is wrong in orthopedics, right? Maybe you want implants, but because you have long screws, right? Let's say you want to put in a screw which is 22, you know, centimeters, but the screw that you have is very long. Maybe your minimum measurement of screw you have is, for example, 50, but you want to insert a 22, you know, maybe on a radius or ulna. So you have to cut that screw to a measurement that you've measured using, you know, a depth gauge. So you are frustrated, you know, actually cutting a screw is not allowed. But if you don't do it, are you going to leave the fracture? So you weigh the pros and cons. Is it which one is more disadvantaging? For me to leave the fracture to, you know, it might heal a malunion or 9-union fracture, or I should try and cut the screw to fix. Because I know if I cut the screw and I fix, the fracture will be, you know, will be healed, and I will remove the screw. Even if I know that the rule really doesn't allow me to cut the screw. So those are the frustrations from my own point of view, because we cut a lot of screws a lot, and deep down I know this is wrong because we don't have a range of screws that, you know, that you can use, because screws differ from body size and different, you know, bone and so on. Because the fracture that we do on me is not the same measurement that maybe Kara will need. So different bodies require different body screws. So that's the frustration. Another one, this is quite a general complaint. Another frustration is, of course, payment. In Africa, we do a lot, okay, but the payment is not quite good. It's just basically to make you survive, you know, just to buy food. You get the point. Because in Africa, if you find a person like me driving, people will be surprised. It's quite, you know, rare. But here I see, since I came here, I'm relating. I've not seen a lot of people walking. I see cars all over. As we walk every time, we are even used. But when you go to the work that we do generally, yeah, so those are just quite, you know, a few frustrations. But it's quite good when we enjoy. Thank you.
I think after having gone to see the work conditions at Abbott and listening to Future talk, all of our frustrations seem so minimal and so minor in comparison that it's almost embarrassing to even voice frustrations. But I would think, just sort of similarly speaking, just, you know, being able to provide the best care for our patients and maybe not having all of the instrumentation ready and available, or having problems with sterility and having to postpone things due to, I would say, lack of resources, but not the same type of lack of resources, just the lack of availability to be ready in that moment, lack of resources.
So also, just to tag team off of that, I feel ridiculous talking about it, but we have all these people that work in the operating room. We have all these different support staff, and one thing that's frustrating for me is just communicating between all these people. So it's, again, just sounds absolutely ridiculous because, you know, he's coming from a place where he's doing everything. So my biggest frustration during the day is definitely just communicating through all those different support staff, surgeon, nurse practitioner, pre-op nurses, anesthesia. I feel like I'm just constantly on the phone communicating. So that's, I think, a breakdown that we have. But, you know, it's so wonderful to have all those support people, but then there's communication that goes on between them. So that's my biggest frustration.
Go ahead.
No problem.
Mine is all theoretical. It's just what I envision to be a perfect healthcare system, which, you know, we've got a really good one, but I would like to see a healthcare system where, you know, all people are treated equally. Their diseases or injuries are triaged appropriately based upon the acuity of them, not upon the patient's ability to pay or their reputation or standing in society. And just seeing how things like that can drive our for-profit healthcare system, which, by the way, I love our healthcare system. I don't know that there's a better one in the world, but it can be improved upon, and there are frustrations with that. So I think mine, again, are minor compared to what Future or Dr. Beza deal with.
Yeah, I mean, Future describes it very well. I feel like I was watching my own hospital when he's presenting what is his. If you ask me frustration, now I'm seeing a lot of things that I didn't know before, like when they use instruments, some of the time, some of the sharp things, we usually reuse them, but here it is not, they are not reuse them because of the danger they bring to the patient as well as to the workers, to the nurses, and to the doctors that are going to work with them. But when I go back home, the frustration I have is like, now I'm learning a lot of things here, and when I go back, I'm quite sure I'm not going to have what I have been taught here, and that frustrates me a little bit because something you don't want to do is harming patients, and something which is considered harming patients here is practiced in my country. That's a little bit frustrating. But Future describe it very well, what's going on in my country. Yeah.
Thank you all for your answers. Based off of that, like, I know at least in the U.S. the burnout rate is very high, and Maureen, you were touching on that. So I was wondering, what have you guys seen that has been helpful in retaining nurses, either in the U.S. when it comes to just like the stresses of the day? And I know that you guys said it felt kind of silly to talk about, but it's still stress, right? And then Future and Dr. Beza, for like if there's resource constraints or say like migration changes or something, how do you guys
So, yeah, it's embarrassing to talk about. So, I'm thinking about, again, here, what's happened. Dr. Headings and I, a couple years back, were gonna look at kind of what happened after the COVID pandemic when nurses were kind of leaving the field or whatever. So he and I have talked a lot about this as far as like retaining nurses and kind of what's happening as far as like what hospitals are doing to retain nurses is like, from my perspective, it's not much. What's happening is it's just shifting kind of on its own, and it's shifting to a model of contract nursing. So nurses are very motivated by money. They want to be paid well. And after COVID, there was a lot of incentives to stay in the field. They were offering financial incentives to pick up extra shifts, to work, and nurses were really happy about this. So now we're kind of coming out of that. A lot of that money has gone away, and nurses are leaving to do contract nursing, travel agency, and then they come back into the hospital on a contract, making more money. So as a staff nurse at a hospital, that can be incredibly frustrating because we see, per my lecture, the value in staying in a place and being committed and having a working rapport with your surgical team. So for us who care, it is really frustrating, and it's one of the things that I hope to find out more about. How can we retain nurses as staff nurses in the hospital?
Okay. Just adding on to what Lori has said, I'm giving a perspective from where I'm coming from, not just my hospital, but as a country and also Africa in large. So nurses, back in Africa, nurses like coming, to overseas. They like coming to US, UK, and so on. In short, abroad. So basically, that is like, the abroad is like everyone's dream. I'm giving you from what is on the ground. So America, UK, or anywhere Australia, it's like everyone's dream back for nurses at home. Not just the nurses, even also medical practitioners. So that COVID impact, if I'm just to relate, it's like kind of prevented nurses more from, coming abroad because there was some, borderline, you cannot move because of the pandemic and so on during the quarantine period, if you remember. Yes, so when the quarantine period like finished, because it's like your dream has, somehow like resumed, okay? So in short, mostly Africa produces a lot of nurses, and because of the little payment that is there in general, because they don't get a lot, as compared to how, nurses get here. If you compare the salary there, it's just like, I'll say like 10 times better that, nurses here get, because they will just, they just get to, just to buy food and so on. You don't really get to do any other thing. So it's everyone's dream. So it's difficult to retain nurses in Africa. Whenever one has an opportunity, they actually go abroad. Not just nurses, any doctor, any orthopedic surgeon. Sure.
Yeah, so on that note, we hope that these programs will help retain nurses in Africa and also here at KU. Because I feel the same way that I think nurses want these experiences. They want to help contribute to the nursing community globally. So I'm hoping that these experiences, traveling abroad, seeing other nurses.
And just to kind of add on that, I feel like the majority of people who go into healthcare don't go into it thinking, hey, I'm going to make a lot of money by doing this. We go into it because there is, like a base level of wanting to provide care for people and feeling that we need to give back to our like community, both locally and globally. And so I think by having a program like this available to not only staff here at KU, to be able to find maybe a little more meaning in their work. Not that taking care of patients during surgery isn't meaningful in and of itself, but I think sometimes in the day-to-day that we forget that we can provide a bigger impact than what we're doing just in that moment.
You talked a little bit, Lori, about how increased education resulted in better patient outcomes and it dropped mortality rates. And I know I can speak anecdotally from my medical career since I started in 2001. I don't know that I recall seeing a nurse do something as a result of their BSN that resulted in preventing a death. I don't. Now, I'm sure that happens, and I believe that statistic. But this is what I do know. What I do know, time and again over the years, the things in my practice, and I've seen other practices, affect patient outcomes, are nurses who have stayed with the practice, stayed within a team for years, and they know the routine of those teams, and they know the patients in those teams, and they know how the physician in that team works. And then when that physician forgets something, or that patient who they know and understand over the years is a little out of sorts, something's a little bit different, that nurse who stayed there, in other words, who's been retained in the practice, catches something that is life-saving. So I don't even know that if that data's out there. I don't know that I don't know that necessarily the market at large wants that data out there, because to retain a nurse means you have to pay a nurse more, I would think, as they gain seniority and they earn something. But I think you want to talk about things that I think increase patient outcomes, improves patient outcomes. I think it's retaining nurses and keeping that talent within a team.
Yeah, I can tell you more trainings. Surgery is a teamwork. So it's nothing such a team called you do it by yourself. I would start, because I don't know what you call these persons, but I can start from the cleaners. You need your room to be more clean than you ever think of. So it starts from there. Starts from cleaning the room. That will affect the patient outcome. So it's a teamwork. You just cannot pick a person and this is the best in the room, or this one is not good. Something like that. It's a teamwork. If you are in shortage of a team, then you will do good. So bad practice, if there is a nurse or physician which is practicing bad, that is a shortage of a person in a team. So the patient outcome will be affected in such a way.
And I know that we're running short on time, so I'll end with a last question that, I mean, I have so many that I want to ask you guys, but I think what would be really useful for us to know as this group and as medical practitioners or people involved in medicine here, I was wondering, Future and Dr. Beza, can you talk about, based on your experience so far, what you think we can learn from you guys and what you would want us to take?
There are two questions there. What we can learn from here, isn't it? And then what would want you to do for us. Is that correct? To clarify?
Yes, yeah. And if you mainly want to talk about what we're learning, like what we can learn from you all, I think, because I think in the presentation you covered quite well, like what you're learning from us, but I know that we can learn from you, so.
Okay. So, quite open. It's like I feel like we have 70% of us learning from you more, and then you have like 30% of you learning from us. That's just my analysis, by the way. So I feel like we have more to learn from you, because you almost have everything. So for you, it is, it's easier to do any case that you want, and it's also easier to follow standards, because theory will tell you need this to do step A, B, C, D. Because you have everything, you are able to follow step A to Z. But for us, it's like theory will tell you have to start from step A to Z, but maybe out of those, maybe you just have a little. Now you have to start improvising. So we do a lot of, improvising a lot. Not that we don't have, of course we manage, but because of the limited resources. So we quite like jump a lot of, a lot of steps. But in as much as we jump steps, we are still cautious not to, to violate either patient's right or to jeopardize your own also waiting ethics. So we try by all means, but we have more to learn from you, because you almost have everything, and I feel like you follow standards. But also you can learn from us in a way that you see how much we improvise. You can also learn from us. If you allow me, I don't want to use, there's a term that I would have been comfortable with, but you people, because you have a lot, you throw a lot of things, of which I've noticed where I'm working from almost everywhere, yeah. This one comes in, you know, you have a lot of grafts, you have a lot of, you know, implants. Just one single drill bit. After using it, I was surprised they want to throw an X fixator. You want to back home, that an X fixator one can do a lot of cases, maybe 300. If because when it comes you remove, you again insert it. When it comes to remove, so it can generate quite. If those who are making profit, they can quite make profit of it. That's why I was imagining if I had my own. I don't know if this is necessary. I wish like we had the closer hospital so that we can be getting whatever you throw, we are getting to use, because I feel like there are a lot of things, because you have a lot, you quite waste a lot. So that's the only component I feel like you can also learn from us who improvise, because we have a little, because we improvise, you can learn from us, because yeah, that's what I can say.
For me, I think I've learned so much from here. How far you guys are going to treat a patient. You just don't have a limit. You push to the maximum to treat a patient. That's what I understanding it, because if I had this setup, of course I would draw a drill bit, because when you do stuff, you have to be healthy first. If I had extra drill bits, I would draw those drill bits after I use them, because I am protecting myself and my staff from injuring themselves. And also, I don't want to have a dervis on it and use it on another patient. So that's, for me, it's like you guys go far to give the best medical care that you need. That's what I take from you guys, and that's what scares me, to be honest, when I go back home. How I'm going to do it, and knowingly using some of the things that I'm learning here is wrong. So that's a little frustrating. So I'm a bit grateful to be here and learning from the best. I think we should do the same. We should travel far to help our patients when I go back home. That's what I'm going to try to now fight for my patients. Yeah. Thanks.
Well, thank you all so much. And Dr. Beze, you bring up really good points of like conversations that we should have of, I know the plan is to continue supporting you all, but like we want to make sure that we're able to also support you in like mentally and making sure that you're prepared to be able to go through that and different options that you have. So that's good to know. Thank you very much. And again, thank you so much for speaking as part of the panel and then as the speakers themselves. And then thank you for coming and listening and engaging with this conversation.